Hello and welcome back to my channel, and if you're new, my name is Tracy. I'm a licensed clinical psychotherapist in private practice, and today's video is to hopefully destigmatize dissociative identity disorder and address some of the misconceptions that are floating out in society. And as a trauma-focused therapist who works with dissociative disorders and have had experience in the past 6 years of working with the condition, I've learned a lot about it, and I've also learned what the stigmas are. So in no particular order, I have identified 5 that I would just love to unpack for today. And the first one is the misconception that it's a rare disorder. It's super rare, they say. And it's really not. The statistics show that it's about 3% of the population, but I think in reality it's higher. It's probably maybe about 5%. And one gets dissociative identity disorder because of trauma in their early formative years, in early childhood, prior to age 7, definitely by 9 years old. And so it is not as rare as people think. Number 2, the stigma with the disorder is that some of the stigma is that if they have dissociative identity disorder, that they're dangerous. They're not dangerous. That's a fallacy. That is where movies and books, fiction books and movies, they portray it for sensationalism. But in reality, if a client has never been violent in the past, chances are they're not going to be going forward. So that is definitely a misconception. Number 3, we have to integrate the parts in order for the client to heal, that the parts have to be integrated. That's not true. We can heal the parts, and it is up to those alters if they choose to integrate into the system once the healing is done or not. But it is not our job as a therapist, and nobody on the planet, even the client, we cannot force the integration. It is a choice, and solely a choice for the alters. They get to choose if that's something that they want to do. And I've had some cases where they've done a lot of trauma work, but some of the alters feel like they still want to exist here. They still want to interact and be part of this sort of reality and not integrate fully in. And that is their choice. And I've had plenty of cases where alters, they know that eventually they want to integrate in, and they know when it's a good time to do that. So we can't force it. It's not on our timeline. It is not our choice. It is solely up to the alters. Number 4, I think that's number 4, there's this misconception that if a client with DID switches is where, so you have the host who's the main person who the outside world associates with who that is. So if the client's name is Sally, that's who the outside world sees them as. But the alters there on the inside, and again, to have dissociative identity disorder, there is at least one other alter in the system that can take control of the physical body. So they can bump the host to the back, or co-consciousness. And so a lot of people think that the switches would be so obvious, that it's overt, that it's so noticeable. And that is simply not always true. In fact, most of the time, the switches are so subtle that even a trained professional who's working with a client with DID over time isn't always able to pick up that a switch has happened. There are times that I can tell by just certain mannerisms, or the eyes will change a little bit, or just the tone of voice slightly, but it's not always so obvious. It can fly under the radar, which again leads to society believing that DID is predictable, that if someone has it, that of course they know about it, or the denial that comes with learning that a loved one has dissociative identity disorder. There's that disbelief of like, that cannot be. I would have known. There's no way that I've dated this person, or this is my daughter who I know. There's no way that they have this condition. That's just not true. When in reality, it flies under the radar. DID is designed for the alters to stay sort of hidden and kind of covertly interact with the outside world if parts choose to do so and they have the ability to do so. But most of the time it's so, like I said, it's just under the radar is the best way to put it. So switches can be anywhere from like a blink of an eye, a switch can happen, to minutes long, although it's rare that I see that. It's usually a couple of seconds before the switch can happen. Another misconception is that the person with DID is so mentally unstable, they can't possibly have a functioning life. And well, that is dependent on the person's history and also what is going on in their present life. But folks with DID can have a family. They can work, a lot of them. They have relationships. They maybe live on their own. Some are super high functioning, some are lower functioning. It all really, it's a case by case. But that belief that like, wow, if someone has DID, they can't possibly manage and live in a world on their own and have healthy relationships or any relationships or have a job. So again, it's a case by case basis and it all depends on so many variables. But the folks that I work with, a lot of them, like I said, they have families, they're in relationships, they're married, they've gone to college, or maybe they're a stay-at-home mom. It is such a range. It could be your next door neighbor. It could be a provider that you have. Like, they're people just like everybody else who happens to have a complex condition, but when they have these alters, they help the client navigate through life. The problems come in when, because alters usually have post-traumatic stress disorder because they took on a lot of the traumas that the host might have been shielded from. The main client, the client themselves, they might have been behind the amnesia barrier during the time of the wounding. But that helps them move forward in their life, right? So hopefully I cleared that up for folks. And the last one that I came up with is people thinking that like, wow, DID it's psychotic. It's not psychotic. There's nothing about it that's psychotic. You know, to have psychosis, you have to have a loss of touch with reality as one of the main components. DID is not that, but you can have DID and have bipolar disorder where, like say bipolar 1, where there's a manic component, and that could lead to some psychosis or mania, sure, but that is a separate issue from dissociative identity disorder. So another way to look at it is if somebody with DID or OSDD goes to see a psychiatrist, there is no medication that's going to help with the dissociative aspect. They'll go to the psychiatrist because maybe they're also having anxiety, or maybe panic attacks, or they can't sleep, or maybe they have a component of, or maybe they have bipolar disorder in addition, and so they will take medication for the mood disorder, with the mania. But DID itself, there is no medication for that. The treatment for that is psychotherapy. And the types of treatments, modalities for DID or OSDD are DBT, CBT, stress management, parts work, ego state therapy, maybe some IFS, and then so those are the foundational, and then eventually moving into some of the trauma work. So EMDR, for example, would be phenomenal for somebody with dissociative disorders. But you have to find somebody who has the specific training for that disorder, because we don't use EMDR in the same way that we would with an individual who does not have dissociative identity disorder. So that piece is very important, that you find somebody that has specific training for the DID. So I hope this video was eye-opening for folks, and I hope that it helps to shift and really lower the stigma that's associated with the condition. It is actually a really brilliant disorder that's designed to help the client survive and get through some of the horrible traumas that they've been through. So I hope this video sheds some light on that and decreases the stigma. If you like my video, subscribe and follow along. See you next time.